Subtypes of T-shaped uterus. Congenital malformations of the female genital tract are deviations of the normal anatomy as a result of abnormal embryological development of Mullerian ducts. Accurate diagnosis still remains a clinical challenge with serious consequences in the management of those patients. Currently, there are two clinically useful classification systems that attempt to categorize the congenital malformations of the female genital tract. In 2013, the European Society of Human Reproduction and Embryology, together with the European Society of Gynecological Endoscopy, published a new classification of uterine malformations. Class U1, dysmorphic uterus, incorporates all cases with normal uterine outline but with an abnormal shape of the uterine cavity, excluding uterine septa. Class U1A, or T-shaped uterus, is characterized by a narrow uterine cavity due to thickened lateral walls with a correlation 2/3 uterine corpus and 1/3 cervix. It is our observation that within the class U1A there are three different clearly differentiated subtypes. T-shaped uterus presents a narrowing at the level of the middle third and a normal interostium distance, which is usually around 2.5 centimeters. On hysteroscopy, a tubular uterine cavity is observed. Advancing the hysteroscope up to the uterine fundus, it is very difficult to visualize the tubal ostium because they are very lateralized. As we advance the hysteroscope, the narrow uterine cavity is appreciated. Note that once the hysteroscope is advanced up to the uterine fundus, the tubal ostia are difficult to visualize since they are situated very laterally. A panoramic view of the uterine cavity reveals a very tubular image in which the muscular rings can be visualized on the uterine walls, making the cavity much narrower. When the hysteroscope exits the uterine cavity, it is easy to appreciate the circular muscular fibers that give the narrow appearance to the uterine cavity. It is important to highlight that the muscular fibers of the myometrium have the following disposition. There is an outer layer of smooth muscle longitudinal fibers, a middle layer in which the muscular fibers have a figure-of-8 configuration, and an inner layer in which the muscular fibers have a circumferential disposition. This inner layer of muscular fibers are easily appreciated during the hysteroscopic evaluation of these subtypes of uteri. Y-shaped uterus. In addition to the narrowing in the middle third, the interostium distance is usually reduced. There is a small indentation at the fundus that mimics an arcuate uterus. The uterine cavity has a tubular shape in the middle third with the presence of muscular rings. Here, it is easy to visualize, as highlighted by the white arrows, the thick, muscular, concentric fibers that narrow the uterine cavity. Once the hysteroscope is inserted past the narrow portion of the uterine cavity up to the fundus, the entire uterine cavity is appreciated. The uterine fundus has an indentation that prevents the visualization of the tubal ostium unless the lens of the hysteroscope is angulated to the cornea. In this view, the tubal ostia are visualized, as highlighted by the white arrows. Appreciate the indentation located at the fundus that gives the uterine cavity the Y shape in which the tubal ostium are positioned in the distal and lateral portion of the cavity. I-shaped uterus. There is almost no difference between the upper, middle, and lower part of the uterine cavity. In this subtype, the uterine cavity has a tubular shape up to the fundus with the interostium distance greatly decreased. We can easily appreciate in this view that the uterine cavity keeps the same width from the internal os up to the fundus, in which the tubal ostia are both easily visualized due to their proximity. Note how the multiple rings of smooth muscle are easily appreciated, giving the cavity the characteristic tubular appearance of this subtype. T-shaped uterus is a rare uterine dysmorphic variant associated with poor reproductive outcome. Recognizing these three variants of T-shaped uterus could have an impact on choosing the recommended technique for optimal surgical repair. Further studies are needed to describe the reproductive outcome of these three different types of T-shaped uterus before and after undergoing hysteroscopic metroplasty. Creating a detailed subclassification system of T-shaped uterus that have clearly differentiated characteristics will allow a more specific management, which could result in better reproductive outcomes of patients presenting with this rare uterine anomaly. We conclude that using 3D ultrasound imaging and hysteroscopy, it is possible to identify 3 different subtypes of dysmorphic type U1A uterus: T-shaped, Y-shaped, and I-shaped uterus.